So I'm delighted this morning to introduce my colleague, Uche Aneni. Dr. Aneni is a child and adolescent psychiatrist and an assistant professor of child psychiatry, biomedical informatics, and data science at Yale University. She receives her medical degree from the University of Ibadan in Nigeria, her master's in health sciences from Johns Hopkins. She completed her residency and was chief resident at Duke University Hospital, and most recently completed her child and adolescent psychiatry fellowship at Yale University School of Medicine. The overall goal of her research is to improve access to preventive interventions for adolescents at risk for substance use and mental health problems. Her research interests focus on developing, testing, and implementing preventive digital interventions, particularly culturally informed family-based interventions for racial and ethnic minorities. Dr. Aneni's research is supported by NIDA, the Center for Technology and Behavioral Health at Dartmouth University, an NIH AIM Ahead program grant, the Doris Duke Charitable Foundation, and the Yale Center for Clinical Investigation. And I'm delighted to share that she was recently scored in the top 3% on a NIDA K23 Career Development Award. And with that, I'm turning it over to Uche.
Thank you very much, Jose, and thank you, Lisa. Sorry, I couldn't unmute quickly, so thank you when you mentioned my name. Let me share my screen. PowerPoint, okay. Can you all see my screen?
Yes.
All right. I can't, because I'm sharing with my, let me see if there's a way I can see. Okay, I can't see anyone, even though, so I'll have to make it work that way. Let's see if I can change the view.
Yes, usually when you share your screen, you're not able to see the group.
Yeah, okay, well, we'll keep going. You can still see my screen?
Yes.
All right, okay, I'll get started then. Thank you so much for coming to my talk titled Substance Use Among Black Adolescents, Maximizing Strengths and Overcoming Barriers in Substance Use Prevention. I have no conflicts to disclose, and I'm hoping that I will talk about and we'll explore together backgrounds and current gaps in substance use, specifically focusing on Black adolescents. I'm hoping to discuss the patterns of substance use over the past decades, specifically focusing on risk and protective factors among Black adolescents, problems with access and care, and the role I think digital interventions can play. And then we'll talk about cultural sensitivity in substance use prevention, and the role that tailored digital interventions could play, with a focus on family, the role that family plays in substance use prevention, and some conclusions. And so starting with trends in substance use among Black adolescents. We know historically that Black adolescents have had lower rates of substance use compared to other racial ethnic groups. As you can see, this is data from the Monitoring the Future survey showing the trends over the last, between 1975 and 2017. And across the board, here between among 8th graders, 10th graders, and 12th graders, it seemed like Black adolescents were using substances, had a lower prevalence of substances. And at some points in the early 2011, it seemed like for particular substances, the use among Black adolescents was rising. This is for any illicit drug other than marijuana, so it seemed like marijuana may have been explaining the closing and gap that we were seeing over the recent years. And this is the graph for marijuana. Alcohol, the same thing. Black adolescents were using less substances in general, but it seems that the gap between Black and white adolescents, for example, were closed in. And similar, the same story for cigarettes. How about in the last 5 years? So this is also data from the Monitoring the Future study, and you can see clearly. So Black adolescents are the red line. For marijuana, as of 2017, if you look at this, the marijuana graph, at some point in 2017, it seemed like for past 30 days, prevalence of marijuana, Black adolescents had overtaken by 2017. And by 2018, you're seeing that sustained across the last 5 years. And for alcohol use, so that's the graph in the middle, for the first time, Black adolescents overtook other racial ethnic groups. Same for cigarette use. What about the consequences of drug use? We know that the consequences of drug use among Black adolescents are dire. This is data showing nearly 3 times the rate of arrests. This data was collected for both adolescents and adults, so it didn't really specifically look at adolescents. But the rates of arrest among adolescents are even higher. Some studies report up to 6 times the rates when it's associated with drug use. And this study showed, as you can see in this, the data shows that more Black adolescents are being arrested for drug-related reasons if you compare that to white, even though the use is lower across the board. The reasons drug use is lower across the board when you compare their percentages to white adolescents. And when they're arrested as a result of drug use, the consequences also are even more. So this data was showing the probability of high school dropouts when after an arrest. So Black adolescents were more likely to drop out of high school compared to those who have been arrested. And you can see across the board, when there's no arrest, the probability of high school dropout is similar between white, Latinx, and Black. And the probability of high school dropout among Blacks is highest for any of those groups. They're significantly more likely to drop out compared to white adolescents. And this difference that you can see among Latinx seems to be explained by the color of their skin. So Black Latinx adolescents had a higher probability of being arrested if they had a high probability of dropping out from high school if they had been arrested as a result of drugs compared to if they hadn't had a drug-related arrest. And we've seen that between 2019 and 2020, the rates of overdose deaths among Black adolescents rose, and it was the highest among any racial ethnic groups. This graphic shows for all the entire population, but the rates was even highest among Black adolescents aged 15 to 24. So this shows a rate of increase from 26% to 39%, while among adolescents, the increase in death rates between 2019 and 2020 rose by 86% among Black adolescents, and the Black adolescents aged 15 to 24 was the highest rate increase in that year. In addition to differences in prevalences, data has also shown that Black adolescents appear to have different patterns of use and trajectories of use, and these appear to vary by substances. So on the left, this graph shows trajectories of use focused specifically on alcohol. The top graph here relates to Black adolescents, while the lower graph relates to white adolescents. And on the right, I have marijuana use. And this study showed that there were two trajectories among Black adolescents. So the moderate heavy drinkers and the non-heavy drinkers, as opposed to white adolescents, we seem to have 4 different trajectories in groups of heavy drinkers. Marijuana use tended to, it seemed, at least from this data, that the trajectories seemed to be the same. They had 4 groups, and those tended to be roughly similar between Black and white adolescents. And then the same group looked at typology, so the types of substances that Black adolescents and white adolescents are using, and the data seemed to fit 4 types among Black adolescents and 5 types among white adolescents. Across both groups, The largest population of adolescents were not using, although you can see that non-use was higher among Blacks compared to whites, but that the most prevalent type of group of adolescents were those who were using a combination of alcohol and marijuana use, as opposed to like white adolescents who had a predominant alcohol use. And the next was a combination of all three, the most three common substances between white and Black adolescents, but it seems like white adolescents were using more. And so the point here is that even between that the ways in which Black adolescents use substances might differ between them and other racial ethnic groups, and so important to consider when we're thinking about prevention. Again, this study looked at different types of the three most common substances, so marijuana only, cigarette only, alcohol only, and then a combination of the three. As you can see here, Black adolescents were more likely to be in the marijuana only group compared to white adolescents, and were also more likely to be in the alcohol plus marijuana use compared to white adolescents, but then less likely to be using any combination of other substances compared to white adolescents. But then also, even though Black adolescents tend to be different from white adolescents in terms of their pattern of use, they're not homogeneous. So this study done I think in the 90s, 1988, it's an old study, but it looked at the perception of risk of harm and drug use between Black adolescents who lived in rural settings and Black adolescents who lived in urban settings. And they were comparing their perception of risk of harm from drugs compared, alcohol and drugs compared to weapons. And what they found, so focused on the prevalence in the parentheses, that in general, adolescents who lived in rural settings were more likely to perceive that alcohol use was a problem compared to weapons, even though there was no difference in their perception of risk of weapons in general, carrying weapons. But that urban adolescents tended to think that perception of risk of harm from alcohol was less of a problem than weapons, for example, and also tended to think that it was less of a problem compared to adolescents who lived in the urban setting. This is from the same study, and they looked at the use. And so overall, even though Black adolescents in rural settings had a lower prevalence of lifetime substance use, but a higher prevalence of past 30-day use. And among those who were using, those who lived in the rural settings were using on more occasions than those who lived in the urban settings. And this seemed significant for only alcohol as opposed to like other substances. Another patterns of use that I don't show here, but that have been documented in literature, that it seems that the patterns of initiation appear similar between Black and white adolescents for marijuana, but Black adolescents in general tend to be using alcohol and cigarettes at later ages compared to white adolescents. So in general, in summary, Black adolescents differ from white adolescents in their patterns and typologies of substance use and consequences of substance use, suggesting underlying differences in risk and protective factors. And so we'll delve into, we know that there are universal risk and protective factors like parental monitoring, parent-child cohesion, so I won't focus on those. I'm going to focus on factors that seem to carry a unique risk for Black adolescents. And so we'll start off with racism. This was a study done by the group that developed the SAF intervention, so the Strong African American Families intervention, which is only culturally grounded. We'll talk about cultural sensitivity, family-based intervention. And they used their data to examine the influence of racism on substance use initiation. And across the board, with the three most common substances, racial discrimination increased the likelihood of substance use initiation, 10%, 15% for alcohol, and 12% or 13% for marijuana. And a study that we published last year looking at perceived racial discrimination and poly substance use among minority adolescents, we also found a similar picture. We didn't focus only on Black adolescents because of the sample, so we combined adolescents from all the racial ethnic groups if they identified as a racial ethnic minority. but Black adolescents made a third of the population in this analytical sample. And so perceived racial discrimination was used a question asking if they've ever perceived that they were discriminated based on their race, ethnicity. And the questions, the responses range from never, rarely, sometimes, most of the time, always. And we combined these frequency into one option versus rarely or never. And in the unadjusted model, you can see that adolescents who reported that they experienced racial discrimination, sometimes, most of the time, or always, were nearly 3 times more likely to report polysubstance use. This relationship held when we controlled for demographic factors. It was still significant when we controlled. This was a study done by the CDC during, so this was a nationally representative sample done by the CDC during the pandemic. And so in this model, we controlled for things like cyberbullying, depression. And even after you control for that, there was still, among those who perceived racial discrimination, there was a 52% likelihood of reporting polysubstance use. How about protective factors? Some of the factors that we'll delve into Black pride and racial socialization. So racial socialization is the process by which parents prepare their adolescents to deal with racist encounters. And Black pride is the process by which adolescents feel pride in their African identity, or Black identity. So this study looked at 272 Black girls who aged 10 to 15, and they were looking at the association between these factors and past 30-day substance use frequency. And they measured stereotype images. Stereotypes here assesses endorsement of negative stereotypes of Black girls and Black women. Things like Black girls are loud and have an attitude. And then colorism assessed the rejection of stereotypically preferred physical traits that stem from a standard of beauty consistent with colorism. So white complexion, straight hair, long hair, thinness, where higher scores denoted appreciation of traditional Black standards of beauty. And they measured racial socialization using the teenager racial socialization scale with 5 subscales, which were cultural coping with antagonism, pride, legacy, appreciation of the Black legacy, alertness to discrimination, and endorsement of the mainstream. And so one of the findings was that those adolescents who appreciated or traditional Black standards of beauty, so colorism, were less likely to report were less likely to use substances. And this is from the same study, and they did a hierarchical logistic regression model. And across the board, we see that colorism, so an appreciation of Black standards of beauty, was associated with lower substance use across the models, even in the fully adjusted model. And also that racial socialization pride was also associated with reduced substance use. There seemed to be like an association between socialization, coping, and substance use here, which may suggest that particular racial socialization practices may be more effective than others. And this was a study too that looked, a different study which looked at racial identity and substance use, and also found reduced, the more you identified strongly with your identity positively, the less likely you were to use substances, and the more you identified with your racial identity, the more likely you were to endorse negative attitudes towards drug use. This was a good finding in terms of, even though it was positive, because negative attitudes, the higher your score, the more you were endorsing negative attitudes for substance use. And this other study was looking at the influence, was testing a theoretical model of how empowerment, so feeling that you had it within you to solve your own problems, and how that related to ethnic identity and substance use. And the pathways that fitted the model is shown here. And as you can see, that the sense of empowerment influenced your sense of ethnic identity, which tended to also reduce the likelihood that you were using substances according to these substances. We know about this idea of parenting style and parenting styles that are more protective. And so this was a study done, a nationally representative study using the National Longitudinal Study of Adolescent Health. They had 3 waves, but they used cross-sectional data of wave 1 in 1994 to test this association between parenting styles and substance use risk among adolescents by different racial ethnic groups. This health risk behavior here actually relates to 5 items assessing alcohol, cigarettes, and marijuana use. So we're talking about substance use here. And you can see across the board, we know that authoritative, so democratic style of parenting tends to be the most protective. And so across the board for all adolescents, authoritative parenting was protective. But we can see here that authoritarian parenting, which tended to be one of the ones that is not necessarily recommended, so there's more control, parental control, tended to be less of a risk for Black adolescents compared to white adolescents. And some of the thinking around this is that historically, Black parents have had to enforce more control over their adolescents because the risk of if something happened to you outside is more dire for Black adolescents within the context of historical structural racism. And so it wasn't as associated with negative health outcomes as opposed to the risk that it, say, carried with white adolescents who were more likely to be exposed to authoritative styles of parenting. And then finally, the data from the Strong African American Families Program. This was a study just recently published, testing their theoretical model, SAF targeted racial socialization and adolescent Black pride. And as you can see here, it did increase parental ability to racially socialize, prepare their children to handle situations of racism, that influenced an adolescent's sense of pride in their identity, which then improved their psychological functioning and decreased their likelihood of substance use problems. We also did a qualitative study, which was just published 2 days ago in JCAP, exploring risk and protective factors among substance use among Black girls. This was a focus group with 63 Black girls aged 13 to 18 years, residing in urban New Jersey. And 4 themes arose, not surprisingly, stereotypes of Black girls. And so if you hear someone saying, "You're ghetto," typical Black girl, they typically might see me as an angry person. I think it could have a lot to do with me being a Black girl, because I don't see myself as angry. But they do say things sometimes that get me angry. And then the physical environment. It's a lot of danger and a lot of crimes, and like they said, drugs, but it's still a good place if you know what I'm saying. It's a good place. And so this tension between, you can't just, criminalize my environment. It's a place where my community is. How can you harness the strength within this community and, release, at least, the way I see it is reduce my risk within where I live. This is where my family live. How can you harness the strengths? Using drugs as a coping mechanism, if you forget. And then prevention programming with a sub-theme involving family as a protective factor. So says, I think it is that. And so Black adolescents have unique risk and protective factors for substance use, underscoring the need for culturally sensitive preventive interventions. However, whether a Black adolescent receives an intervention be tailored, I think, disparities in accessing mental health care. This is a study which is in press now, was testing the association between family functioning and access to mental health care. So the outcome was those who needed parents responded to this question. He used the National Survey of Children's Health, so it's a nationally representative sample. And the outcome was access to care. So did your child need care in the last year? And if they did they receive it? And so those who needed care but didn't receive it. And as you can see here in our table, table 1 of demographic factors, Black non-Hispanic youth were 2 times more likely than white non-Hispanic youth to not receive needed mental health services. This didn't specifically focus on substance use, although parents could have assumed substance use when they were responding to this question, because it just asked mental health in general. This was a study that looked specifically at service use, substance use service use, and you can see here that Black adolescents were less likely, so the prevalence of Black adolescents, mean prevalence of Black adolescents who were using this treatment, specialty treatment related to meant outpatient treatment, while informal treatment meant things like self-care, self-help. And in general, Black adolescents are using less of these services compared to white adolescents. Even you might say compared to adolescents across other groups. And then I hope you can see this as well, but this was a different study looking at treatment completion. The data around prevention is sparse. And so I'm presenting some data with substance use services in general and treatment. But here you can see that Black adolescents were more likely to not finish treatment. So treatment incomplete percentage, but 9% compared to 35%. And then the reasons for not completing different also seem to show significant disparities. Black adolescents were more likely to be terminated by the facility and more likely to stop treatment because they were incarcerated. This was for alcohol, the same relationship held true for marijuana treatment. And so this was a study looking at trends about the past decade of prevention programs. So it focused specifically on prevention programs and looked at the trends of school-based participation and community-based participation. And in general, 1 in 7 adolescents are participating in prevention programs, so woefully low to begin with. The decline in school-based has been steeper than community-based participation. And you can see on the left that the percentage point change between 2020, because this is 2002, sorry, and 2016, was steeper for Black adolescents, significantly steeper than white adolescents. No difference in community-based, which may be because even though it seemed to be steeper, but I mean no difference. But it could be that many of the interventions that target Black adolescents have historically been in community-based settings. And so what are the barriers to mental health seeking among Black families? This factors taken from a systematic review and so compiled findings from several studies that had looked at mental health seeking in general. So this is whether Black families will seek mental health, and so not necessarily focused on substance use, but that data, like I said, is sparse. And they found barriers across 7 levels. Some of the child-related factors that seemed unique were this cultural trope of self-reliance. We should rely on ourselves. We have survived a lot as Black people, and so we can do this. And then PCPs, primary care providers, attributing this to a phase, so not taking the time to assess what's going on and then adequately refer them. We know that Black adolescents are less likely to be referred to treatment in the primary care setting. And then the fear of consequences. Children don't want to disclose anything because my parents will be taken away. It's happened before. Black adolescents are more likely to, Black families are more likely to be reported to DCF than white families. And then prior negative experiences, perception that treatment is not effective, are things that clinicians have said, families have told them. And then the stigma and shame, which seems to be amplified through the Black adolescent social network. And so there's a fear of embarrassment and exclusion. You couldn't, relating to this culture, you couldn't do this by yourself. And also some stigma and shame experienced by caregivers as well. What would people say about my ability to manage my children and manage behavior? Religion and spirituality, lack of information about mental health treatment in the church. We know that the church is such a huge part of prevention efforts in the Black community. And then the reliance of spirituality without necessarily seeking professional help. And where's that connection among leaders, Black leaders in the church? Cost is a major issue. Lack of transportation, convenient time. So how is the system thinking about that? If you think about the fact that because of historical and structural racism, the wealth gap between Black and whites is large. And so Black families tend to be in lower socioeconomic class compared to white families, and those factors influence how many jobs they're keeping, and as a result, whether they can make times for disappointments, how we think as a system about how we accommodate. And then the school system, zero tolerance for behaviors. We already know that Black adolescents are more likely to be suspended than white adolescents. And so would they disclose? And even when the school has a way to prevent, will they disclose such that they can receive these interventions? Caregivers are also wary of the school system, and it seems like, teachers have reported that those who live with their grandparents, a group of foster homes, were harder to be engaged. I'm sorry, that's what I meant here. All right. And so in summary, Black adolescents have unique risk and protective factors for substance use, as well as distinct barriers to accessing mental health care and substance use interventions. As such, interventions that address substance use among Black adolescents must be tailored to address these distinguishing factors. And so it brings us to cultural sensitivity. I like this definition by Renisco, which defines cultural sensitivity as the extent to which ethnic cultural characteristics, experiences, norms, values, behavioral patterns, and beliefs of a target population, as well as relevant historical, environmental, and social forces, as they are incorporated into the design, delivery, and evaluation of targeted health promotion materials and programs. So it's not just the intervention, right, that is developed that incorporates these risk and protective factors, it's also the way in which we deliver them, we implement them, how we think about where it can be assessed, how can we engage, and so it's all encompassing. And one of the ways that cultural sensitivity has been defined that there are different levels of cultural sensitivity. Renisco defines the surface level, which is the use of people, language, clothing, settings, music, and exemplars that resonate with the population. So, for example, you deliver an intervention by someone who looks like the population, or say in a digital intervention, you had people in the intervention that look like your population. While DEEP incorporates and integrates social, historic, psychological forces related to health and wellness, I see this as the integration of the risk and protective factors. Kammarauche has also defined cultural sensitivity in a different way, which is adapted versus grounded. And so adapted he defines as those that just modify existing evidence-based program, and you can see how this can exist along a continuum of surface to deep level, and then grounded, which will be designed originally with the group in mind, so that the program reflects the values, behaviors, and norms of the target population. And he cautions about their strengths and limitations about different of these ways of adapting or developing culturally tailored approaches. For culturally grounded intervention, the community is engaged and invested in this development, but it may be time consuming. And on the other hand, with surface structure interventions, you just test something very generic, which may not be acceptable or seen as disconnected from the community, and may lack, even though it's fast to implement and scale, may lack, core cultural components that influence these health outcomes. And so, what's the evidence for culturally sensitive interventions for substance use prevention among Black adolescents? This is a table showing 5 meta-analyses of culturally sensitive interventions among minority youth. And in the second column, I highlight the number of the studies that focus specifically on the Black population. These meta-analysis focused on children and adolescents, focused on prevention and treatment, and I looked specifically at the effect sizes for substance use-related outcomes. And as you can see here, that the effect sizes ranged from low to moderate effect sizes, but pretty good, all significant effect sizes for these 5 meta-analyses. So if we have evidence to suggest that culturally tailoring interventions for specific populations are effective, why aren't they widely implemented? One way to think of levels of substance use prevention is think about the levels of substance use prevention. And so you may think about universal interventions, which target all adolescents, regardless of their risk, and selective interventions that target specific risks, so maybe adolescents who have experienced trauma, adolescents who have been exposed to violence, adolescents, say, with mental health disorders that increase their risk of substance use. And then indicated interventions are specifically focused on adolescents who are beginning to experiment with substances. And so with this in mind, what's the current approach for addressing adolescent substance use? I think it's fragmented. if we look at school and community-based settings, you have these types of interventions, but they're largely driven by funding, research funding. And when you have those funds, well, school officials want you to implement those interventions in your school settings. They're gatekeepers. But in the school setting and the community-based setting, there's no systemic approach for screening and assessing and delivering this intervention. Policies that guide how this should be done that is adopted on a wide scale. And then when you focus on the primary care setting, there is some structure because it's recommended by the American Academy of Pediatrics and some, I think these are the reasons why I think that there's more of a structure in the primary care setting. We have CPT billing codes for, before I get into that. So the recommendation in the primary care setting is that all adolescents are screened at least once a year, and then you deliver a universal intervention. And then you triage based on high risk, so or early misuse or a substance use disorder, and those with high risk should get a targeted intervention, or those with the disorder should get treatment. So what we typically call SBIRT, screening, brief intervention, and referral to treatment. So it's recommended, and so facilities try to figure out a way to implement this. There are CPT billing codes for SBIRT, so which is one of the barriers that primary care providers have talked about. And even though it's not a required quality metric, tobacco screening is a voluntary quality metric by Joint Commission where you can get some incentives if you do it. And so some systems may incorporate that basically into their workflow because of those. And so there's more of a structure. However, there are barriers to implementing substance use prevention across. So this is looking at implementing substance use prevention in general. And for universal interventions, you can imagine that the provider workforce, we simply don't have the workforce to meet the demand. It requires time and training of teachers and primary care providers, and there's no reimbursements that I know of in the school setting, and then it costs a lot of money. For selective and indicated interventions, we don't have trained specialist providers to meet the demand. Providers have cited lack of knowledge about resources, what to do when an adolescent screens high risk, for example. What do I do? Where do I refer them to? For universal interventions, a caregiver might think that this is really not a priority, especially if they're thinking about how to get their adolescents into college and they don't have the time. Is this really a problem? Same thing with the adolescents. And then when they know it's a problem, so what do I now do about it? There are confidentiality issues. Do I disclose to the parent? When do I? And especially if you were thinking about a family-based intervention. And then, of course, when among the adolescents, stigma, low perception of risk of harm from substances, and fear of being punished. How about specifically in the primary care setting? So this has a structure. I'm particularly interested in implementation in the primary care setting. And we can think about the different levels of barriers. Primary care providers have cited that adolescents are not always forthcoming, and so why should I screen? There's no privacy in the primary care setting. Parents may not be aware, so how do I engage the parents in this intervention if I screen? I don't know what to do, where to refer them to, and then there are time constraints, and you can't always bill depending on what it is and how much time it takes. Primary care providers have a 20-minute slot to see patients, so we constantly ask them to do more and more things, and so they have to prioritize about what they're going to focus their 20-minute time on. So on the left-hand side, you see the most frequently cited barriers. There's a lack of on-site providers and a lack of readily available treatment resources. Okay. So I don't think digital interventions can solve everything, but I think that it may address some identified implementation barriers. On the left-hand side, these figures, except the one in primary care, relates specifically to Black adolescents. So 93% are enrolled in schools. Whether they attend frequently is a different issue. I don't have that number. That number is difficult to find, but 93% are enrolled in schools. So the idea that you might be able to engage them. 90% have access to a smartphone. 91% of adolescents in general are seen in primary care annually. 90% of Black adolescents report having internet access, and 80% live in So there's a wide reach in terms of digital cell phones and potential to deliver interventions on smartphones, for example, or even non-smartphones, text-based interventions, for example. That seems pretty popular among the Black population. It can solve the issue of time constraints if you don't have to worry about fitting this into a 20-minute visit. It can be delivered anywhere. There's some studies beginning to suggest that adolescents feel less stigmatized when they're engaging in an online intervention or a digital delivered intervention. There's a potential for EHR integration. Think about if you could push this through a My Chat, for example, even though there's some studies suggesting that the uptake might be low. And then provider buy-in certainly would help with the time that providers have to now spend delivering an intervention if they didn't have to do it. So it brings me to this idea of standalone interventions. And standalone digital interventions I define as delivered entirely without the need of a provider. So maybe delivered in any setting. It could be mobile-based, web-based, computer-based, if effective, would elevate existing provider burden. So what's the efficacy of standalone interventions? And are there differences by racial ethnic groups? So we did a systematic review and meta-analysis among adolescents aged 12 to 17, and we focused specifically on universal and selective interventions. These were randomized controlled trials. And these studies, randomized controlled trials, had to have measured substance use, either behavior or through, either through self-report or objective means, human screens. So we found in general that most of these standalone studies, these studies using standalone digital interventions were conducted in the US, a third were in schools. Only one was done in the clinic setting. We'll get back to that. We looked specifically at the three most common substances, a third were universal. One third of them involved parents and one third of them were single sessions, so delivered in a single session. We looked at the theoretical frameworks, these were the most common frameworks, and then we looked at the racial ethnic distribution. One thing that here was very striking was the inclusion of American Indian and Alaskan and Native Hawaiian. So we found significant effect sizes and in low to moderate range across these three different substances. And in the subgroup analysis, we found that studies that delivered booster sessions were more likely to be effective. And this is one place where digital interventions can easily be used to deliver boosters. I'm interested in families, and so we looked at the theories that focused on families and all the other theories, and also parental involvement. And one striking thing was that if it involved parents, if this intervention involved parents, the effect sizes were larger. And if it employed family interaction or family systems theory, also had larger effect sizes, although not significant across the board. So we were interested in how this effect varied by racial or ethnic groups, but this wasn't the question, unfortunately, we could answer, right? We looked at whether studies were significant by whether they included racial or ethnic groups, and you can see from the p-value that there's no difference. So you might conclude that, oh, it's significant for all adolescents of different racial ethnic groups. But this gets at something called aggregation bias, where you assume that trends in aggregated data are wrongly applied to individual data. And the way to deal with that is to potentially use individual participant data, or specifically look at culturally sensitive interventions and compare those to non-cultural interventions. But using individual participant data and having the actual data where you summarize the outcomes by different racial ethnic groups and comparing the efficacy of effect size is very hard to do. You have to reach to many people, so it's difficult to do. But the low-hanging fruit might be to examine the efficacy of culturally sensitive digital interventions. And so, in general, digital interventions seem to have potential. Parental involvement is associated with larger effect sizes. We need more inclusive studies. With the evidence for culturally sensitive digital interventions are needed, and implementation in the primary care setting is lacking. And so this is a question we're trying to answer. What's the evidence for culturally sensitive digital interventions among Black adolescents? Thinking about family-based interventions and what has been implemented in the primary care setting. And so going back to this culture, the results I showed earlier, you can see I highlight now specific things, but you can see that none of these interventions that was reported in this meta-analytic review involved a digital format. but also most of them were family-based interventions. This is a recognized way of addressing substance use among Black adolescents, family-based interventions. And so we know that culturally sensitive interventions are effective for substance use prevention among Black adolescents. What's the evidence for digital interventions? So we're currently wrapping up a systematic review examining that. And our preliminary findings so far have 6 studies. We found variation in the level of cultural tailoring, and only 1 study involved all Black adolescents. Only 2 were family-based, and none of them were in the primary care setting. Looking at our systematic review, which we published last year, you can see that only 1 of the interventions, digital interventions, have been done in the clinic setting. So this is a standalone, again, not delivered through a primary care provider. And interventions involving parents, only 1 of them. So 2 were done in the clinic setting for all interventions, and of the ones involving parents, only 1 was done in the clinic setting. We've explored some of the ways in which the family-based interventions are protective. So family-level factors, for example, like parental visualization, have been shown to be protective among Black adolescents. And also we'll look briefly at some work we've done around the influence of family-level factors with influence to, with access to care. But there's a lot of evidence that family-based interventions are effective, not just for Black adolescents. And those specifically focusing on Black adolescents have been effective in reducing substance use. Delving into our paper examining the family sub-themes, here we see that Black adolescents want their parents to be involved. Because of time, I won't go into this in as much detail. But Black adolescents want their parents to be involved, but don't know how. Don't think they know how to help them. But you're seeing here with things that suggest that they know that involving their families in helping them is a useful strategy, and they want that. We looked at this. I had presented a part of the study earlier, but in our paper where we looked at family functioning and access to mental health care, we found that adolescents who reported, parents of adolescents who reported low family resilience were more likely to have unmet mental health needs, so poor access to mental health care. We didn't specifically look at the racial ethnic moderation. So this is not saying that Black adolescents were more likely to, that the relationship was stronger. We didn't assess that. This just suggests that the odds of having unmet mental health needs were higher among Blacks compared to whites. And so one of the things that, putting all of that together, wrapping up a NIDA diversity supplement where I'm exploring the role of family functioning and race ethnicity on the efficacy of an opioid misuse prevention video game for adolescents. This is a supplement to a larger NIDA Hill study. We added additional measures of family functioning, so cohesion, connection, conflict, parental monitoring, parenting practices at baseline at 3 months. And our hypothesis is that adolescents with higher family functioning scores will respond better compared to adolescents with lower family functioning scores. We're also interested in whether there will be differences by racial ethnic groups, which might suggest, tailoring. And also, if the influence of family functioning factors, we talked about how authoritarian parenting, for example, and directive parenting might be different across different racial ethnic groups. So will these family functioning factors differ in the way in which they influence response by the different racial ethnic groups? I think we have 1 or 2 more to complete 3 months, and we'll start delving into the data. And then finally, my NIDA K23 will focus on developing and pilot testing a culturally tailored family-based digital intervention to prevent increases in substance use among Black adolescents, specifically focused on the primary care setting, which I think is an underutilized setting for engaging Black adolescents. And my training aims will focus on gaining mastery on community-engaged research with Black families, acquiring expertise in developing culturally tailored family-based digital interventions, and skills in implementation science methods. So in conclusion, Black adolescents share universal risk and protective factors while also having unique risk and protective factors of substance use. Culturally tailored interventions are effective for preventing substance use among Black adolescents, but are not widely implemented. Family-based interventions have shown effectiveness in preventing substance use among Black adolescents, but digital adaptations are lacking. Data interventions may facilitate wide implementation, but the implementation in the primary care setting is lacking, and standalone data interventions may alleviate some of the barriers that impede primary care setting implementation. I want to thank my family, my patients and study participants, my mentors. A special shout out to Jose Sapochnik, who has an incredible balance of support and challenge, and members of the Access Lab, as well as the Clinic to Prevent Lab. Now I'll take questions.